minutes and then get that information. It is the only way to have a quantitative assessment of a normal or abnormal visual field. It guides us for the diagnosis and also for the follow-up and care of that patient. We have different perimetric tests. We have a standard and we have early detection. We're going to focus more on the standard today, which is standard automated perimetry, which is white on white stimuli, or achromatic, meaning there is no color associated in our testing. It's basically a white stimulus on a white background with different intensities. That's how we differentiate that's how we test the retina sensitivity at that particular point. And then we have the early detection like SWAP or FDT. We're not going to talk about them. They use colors like blue on yellow. They believe that they have an early detection of glaucoma before it becomes visible on the standard automated field. But just for a mention, we're not going to go through that. And then we have static versus kinetic. You just need to know the types of perimetry. And when we say static versus kinetic, meaning stable, not moving, versus something moving, and that's in relation to the stimulus that we give to the patient to see. So if the stimulus is static, it's in the same spot, it doesn't move. That's the Humphrey visual field, static, and it's presented in various locations. So it's one spot that appears in one area, then appears in another area, but it does not move. Kinetic, or the Goldman, is the one where the target or the stimulus moves from one spot to the other, and the patient's being tested while the stimulus is moving from one direction to the other, and then draw the visual field of that patient. Now, unfortunately, Goldman tonometry needs a lot of time and needs a lot of skills, and it has dropped out now for most places where we don't use it as often as we used to do before. So our focus is going to be on the static, and it really helped us as a glaucoma society in diagnosing and following glaucomatous patients very easily. Now, before we go into talking about the visual field, we need to know what are the factors that can affect our results. If you know the factors, then you can always go back and check them if they have been taken into account. So for example, the pupil size, significant meiosis can affect the visual field results, as well as mydriasis. But the small pupil has more bad effect on the results than the mydriasis. So we want the pupil not to be less than 2 millimeters in size, and you don't want it to be more than 6 millimeters in size when you do a visual field test. Increasing age will reduce the sensitivity of the point that you're testing. So it's very important to age match the test, because the test is age matched. And we're going to talk about that more in the coming slides. Clarity of media, also important. If you have a patient with cataract or corneal scar or uveitic changes due to uveitis, inflammation in the AC, or the vitreous hemorrhage, all that can affect the visual field outcome. And of course,
Dr. Gdih,
yes.
May I ask you, please? When you mentioned the pupil size between 2 and 6, do you mean the mesopic pupil?
Well, I mean the pupil size while the patient in that test. So it's going to be the mesopic pupil, yes.
Mesopic, yes. Okay.
Yeah.
And regarding the refractive error, I think there is something, a holder to hold a corrective lens for presbyopic people and so on. So yeah. I think it has. You are going to talk about that, yes, because it has like restriction of the field. All right.
You're right, yeah. So that's why, yes, you're absolutely right. So refractive error can influence and more so with the hyperopic people, because the hyperopic people, they have more difficulty seeing near than far. Therefore, and you know, the target or the stimulus is about 30 centimeters away from the patient's eye. Therefore, hyperopics and people in their presbyopic age, they can be affected by that if we don't correct it. Now, the trial lens holder, which is in front of the patient's eye, should be as close as possible to the eye to minimize the rim artifact of the lens. So that's one thing should be kept in mind. Also, any refractive error should be corrected, and the machine actually gives you a calculation. It will calculate the age-matched accommodation to help you choose the lens for that patient. Any astigmatism that is 1.25 diopter or more should also be corrected before conducting the exam. Now, the newer Humphrey visual field machines, like the Analyzer 3, nowadays they have a lens that's built-in lens, so you don't have to bring a trial lens. It's about $8,000 more to pay for that lens, but what it does, it will change the power of that lens. I believe it's like an air-filled lens or something, or water-filled or something. I don't have it, but it's quite unique to see that. And what it does, the machine will memorize the patient's refraction and dial it in automatically. You don't have to even spend time on that. So that's quite nice to have. So this is an example of a pupil size. The pupil, this is the same patient, same eye, tested just with a 1 millimeter diameter pupil. It showed that visual field. And then when the patient was dilated, then it reached to 5.5. A patient on pilocarpine, and after dilation, they did much better, and none of that was real. This is also before and after cataract surgery. Just tells you how the patient can improve from one side to the other. Now, this is not in the purpose of explaining the details of the visual field, just explaining the physiological factor that can affect your visual field outcome. So we're not going to go about details of these printouts because we're going to have more details coming in the next slides. Now, the lens artifact, especially the plus lenses and the high plus lenses, you could see how they can give you a ring scotoma, but apparently it's not. And one of the things that you look for a ring, like a lens artifact, is when you have sharp borders like this, like stepwise. That's an indication it's not following an RFL defect. And then this is an example of same patient, same eye, when they have done a visual field without their correction or with their correction. So definitely they can do better when they have their refraction in front of them. A droopy eyelid, we should not forget about that. If a patient has a droopy eyelid, and most of our glaucoma patients are elderly and they do have senile ptosis, so if that's the case, we should the technician should be aware of that, and they can tape their upper lid during the testing so we don't get that artifact. Now, this is a visual field of a patient who the first visual field did very bad, and then they did better, and then finally they did much better, almost normal. So what do you think is going on here, Dr. Mazen? When you test the patient first time, they did very bad, and you haven't done any treatment. You brought them next time, they did better, and then third time they did almost normal. So there is something.
I think this annular scotoma is related to spectacles or something related to
no,
that?
there was no spectacle. Like the patient was fine. Just because the first time it didn't make sense, and then a doctor decided to bring them back again and do
The patient was taking pilocarpine, maybe?
No, every other physiological factor was tested. It was good. Yeah, so why I brought this up, I just want people to think about it in a way that there is something called learning effect. Okay, so the patient
learning curve.
Yeah, learning effect or learning curve. Yeah, so if a patient do bad, if there is a pathology to correlate with, that's okay. But if you look at them and examine them and everything looks normal, just bring them back and do it again. And explain the test to them again, like give them more chance to get it right.
So can I intervene for
Yes.
10 seconds or even less?
Yes.
So my rule is the first two visual fields are for the trash can, for the poubelle. Yeah. And for my francophonic friends, what Gdih just showed is what we call a courbe d'apprentissage. So it's the learning effect. First two throw away, at least the first one throw away. And if you can throw the second one, it's even better, and start recording from the third. Sorry about that.
Totally agree. Thank you very much, Dr. Kyle. Okay, so clover leaf. We're going to talk about the clover leaf, how the clover leaf is an indication of unreliable test. So I'm going to explain to you how the clover leaf creates in the visual field. So if we go to the machine, like the Humphrey visual machine, what it does, first of all, it starts testing 4 points in the central area. And we call these the fixation points. And it will start recording the responses there in numbers. So, and then as the test progresses, it goes out from the 4 central points and start testing, around these points and go outwards. So the peripheral points are being tested, later in the test, and the central points are being tested early in the test. If a patient is attentive, so they call this clover leaf, a patient fell asleep at the end of the test. Because in the beginning, they were attentive and responding and everything is good. And then they're sitting in this quiet room, dark, quiet room, for about at least 10 minutes and doing this test. It's very boring. So what happens? They tend to fall asleep at the end. So this is how the clover leaf pattern form. Now, if just a bit of background about clover leaf. Clover leaf, it's believed that the clover leaf with the 4 leaves is the one for luck. They say you find 1 in 4,000 or 40,000 leaves. They're mostly 3 leaves, but when you find one with 4 leaves, you can say your wish. And I think that's more in Ireland. They say that. Anyway, so this is the form, but it's not that uncommon in our Humphrey visual field world. You will see it a lot. Okay, and we have something called high false positive response. What does that mean? Means the patient will respond when there is no stimulus. They are more than responding, or so what the machine does, it's very tricky. A shutter sound without a light stimulus. When you ask the patient when they have white scotoma, they will tell you, I will say, why you keep on clicking? They say, oh, because I hear the sound. So when you go back to explain to them, tell them, do not respond to a sound, but respond to a light stimulus. That's why the machine will test the reliability in different ways. It will test them if they are going to respond without seeing anything by sending that sound. So if you look at this visual field, let's have a look at numerical scale here, okay? if we look at these areas, you see a very high sensitivity here, very high numbers. And by the way, these numbers on the grayscale is translated into numbers in the stimulus response to light. So it ranges from 0. 0 is being the brightest light was shown to the patient, and the patient could not see it. From 0 to 50. 50 is the dimmest light the machine can produce, and the patient will see it. Whenever you see above 40, that means this patient is unreliable. That means they are responding to the clicker without seeing the actual stimulus. So if the technician is attentive to these, they can abort the test and explain the test again to the patient, and then so they don't waste their time or the patient's time. So looking at these numbers here, look at now, if we go like this to the white scotoma here, see the area in the heart, and you look at the numbers in the heart, they're all close to 50. Meaning all these, they are like supranormal, like they see more than the normal, human being can see. And that is not true. Now, if you look down below, whenever you look at a print out a visual field, you will see scotomas in 3 different areas. You see it in the total deviation, pattern deviation, and you see it on the grayscale. But which one means what, and which is the most important to know, and which one is the most important to note and use for your diagnosis? We're going to learn that more in the coming slides. So if we see here, pattern deviation has a big scotoma here. Is this significant? No, it's not. It's just the patients being, overacting, and they're acting to every stimulus that comes through. So they don't, it's usually people with type A personality. They want to get this right. They want to really do this test well. They don't want to fail. So they are overstressed, and they want to keep clicking every time so they don't miss any points. But the machine is smart. It's going to mark them down as unreliable, and then because you're not going to get right information. Now, before we move forward, I'm just going to show you this, not to overload you with information, but just that the machine that you're dealing with have much more options to choose from. There is a visual field called the macula, or the central field of the macula. It tests only about 4 degrees centrally. And we have central 10-2, we have central 24-1, and we have central 24-2, central 30-1, central 30-2, and we also have 60-1 and 60-2. Now, these are not used commonly. We're going to focus on 24-2. Why we don't use 24-1? What does -2 and -1 means? So all this information I'm going to talk about, not in a extensive way, but just that you know why these are labeled this way and why we're choosing the 24-2 and not something else for glaucoma. So this is another information you need to know. How many points are being tested on each strategy? That just it gives you an information that how many times your patient will be clicking in that home. And also it will tell you how many points have been tested in that particular central 24 degrees, so that you were given this information. For 24-2, we have about 54 points have been tested to get 24-2. In 30-2, it's 76 points. You may say, why I need to know this? Because if your patient gets fed up quickly and they give you unreliable results, and you put them to do 54 points and they gave up quickly. So what if you give them 30-2? They're going to be even more tired, and you're going to get less reliable results. because they're going to be testing a lot more points, about 20 more points on 30-2. And similarly for the central 10-2, it tests about 68 points. Now you may wonder, how could 24 and 30-2 test, or let's say 24-2 test less points and gives you wider range of area tested, versus 10-2 test more points but less area of testing? Because 10-2 is a high definition. It goes to that area and tests points close to each other. It keeps on giving, it will give you more defined shape of the scotoma that the patient has. Versus in 24-2, it tests every 4 points. So that means it will skip some points in between. That's how it gets a wider area of testing. And when do we use 10-2 is when we have advanced glaucoma and a central island that's left, or if you're testing something more central, like you're screening for plaque-Winell maculopathy and you want to know more information about the center than the periphery. Now, also keep in mind, all our visual field tests that we do for glaucoma, it does not represent the patient's real life visual field, because we're only testing 24 central degrees. We're not testing way out. So we cannot use it to determine the patient's ability to drive or not, because we have to use the full visual field for driving. Okay, so now what does -1 and what does -2 means? Remember I said in the beginning, when the Humphrey visual field machine starts testing the 4 central points to determine the patient's fixation points, it will then move on and try to determine the midline, the vertical midline and the horizontal midline. It's important the machine knows where the midline exactly, and how it knows that. It knows it either by testing only one, only by testing 1 point at a time, and in what the machine thinks it's the midline. So that's -1. It only tests once to determine the midline, or it will come to the midline and test 1 point on the left and 1 point to the right. And it will just keep on straddling back and forth between the two. That's why it's called -2. Now, the -2 is more definitive in determining and outlining that midline for that patient. So that's why we use it more often. It is now if you want to take a screenshot of this one, go ahead, because what's written in yellow, this is what I want you to go to your machine and select this test going forward for your glaucoma patients. It is the most recommended strategy and test type that you need to use for glaucoma in diagnosis and also for follow-up. So let's go ahead and dissect the 24-2 Humphrey visual field printout. We're going to identify every corner of this visual field and know what every corner means. So first of all, what's in this upper left corner is the patient's name, date of birth, gender, and then patient's identity number if you have for your clinic. And then also the site that's been tested, OS or OD. Now, all of these information are very important. First of all, the patient, you need to identify the patients. You're not gonna, you may have someone else named in, and you're interpreting the wrong patient, so that's important. Date of birth is important because, as we said, the Humphrey visual field test is an age match test. So it uses data that's been stored in it, aged to the normal population according to their age. So if, let's say, for example, if I test someone who is 60 years old and I put down their age as 20, the machine is going to give me a lot of errors and a lot of abnormalities that doesn't exist in that patient. Why is that? Because it's matching it to someone who is 20 years old, and the retinal sensitivity is much higher than that 60 years old. So therefore, it's important to match the age. And then in this area, in this other area here, you have you can put your logo there, you can put your phone number, clinic name, so that will show where the field was conducted. And then we have the upper left corner under OS, we have what we call reliability indices. So it shows us a few numbers here that we need to know. First of all, the fixation losses that to have a reliable field, we should not have more than 25% of fixation losses. And what does the fixation loss mean? When does the machine go and put a number there that the patient lost fixation? Is basically it goes back to the fixation points that it goes back when it determines the blind spot in the beginning, it will go back to the blind spot and test it. If the patient responds yes to the blind spot, it will say, okay, this patient did not keep fixation, so they looked away, that's why they see it, and now we're going to give it a fixation loss, and it will record it like that. So we don't want to have more than 25% of fixation losses. We don't have more than 33% of false positives, which is the patient keep on clicking, it's a positive response, but it's false, or false negative, like the patient does not respond when there is an actual response, when there is an actual stimulus. And then we also have a graze tracker. That's an additional way for the machine to, it's like a little camera that looks at the patient's eye and then follow it. It will give us, see this line below? It will give us, either an upward or downward line. If it goes up, that means the patient lost fixation. If it goes down, that means the patient blinked at the time of the stimulus. So the more you see of that zigzag, the more the patient, this test is unreliable. The more straight line you see, the more reliable the test is.
Dr. Gdih,
Yes.
would you please go back to the previous slide?
Sure.
Yeah, now regarding fovea, sometimes I see it off, sometimes it's on and giving sometimes number in green, sometimes number in red.
Yes. Yeah, so the fovea on is, in the beginning of the test, it will determine the foveal sensitivity. The machine will determine what's the patient's foveal sensitivity, which is usually around 30, either 34 or 30 or around that. This is an additional way that the machine keeps track of the patient. So if the machine loses if the machine tests that area and find a difference in the sensitivity in that foveal area, it will mark the patient as unreliable. It keeps on adding fixation losses. So sometimes it's confusing. That's why I put it off for my testing. Why is that? Because the patient sometimes drift down and they lose their, on their chin, they lose that spot they were on, and then it's the machine will remember that same area where the foveal sensitivity was the highest. But the patient is looking, now the machine is projecting to that same spot that was tested earlier, and it would not find, it will find a difference in the sensitivity. So it will mark it as a fixation loss. I don't know if that makes sense to you, but it's
yeah, thank you very much.
That's what it is. But in simple terms, it's another way by automatically having the machine test for fixation losses or monitor for fixation losses.
Thank you.
You're welcome. And then we're going to look at the, in this area, right in the upper and right in the middle, we have some information here, which is the stimulus, size, and color. Remember, we said we're testing white to white, right? So that's our interest today, is the standard test, which is white to white stimulus. So the stimulus is white, confirmed, and we have the stimulus number 3. The sizes go from 1 up to 5. Depends on the patient's visual acuity and ability to determine size. And size 1 is being the smallest, and 5 is being the biggest. And we use 5 in case there's a very poor visual acuity, or conditions where people don't have, we need to have a visual field, information, but we don't have enough visual acuity to see that. Because those are rare situations, we're going to focus on the majority of our glaucoma patients are able to see size 3. So that's why it's been set as a standard size 3. The background illumination is about 31.5 acetals. And we have the strategy test, which is CETA standard. Pupil diameter, it's not recorded here, but it's something can be recorded. Visual acuity also important, because any visual acuity that is less than 2200 or worse, you're not going to get a good visual field results, because you do need a visual acuity, obviously, to be able to conduct the test. In this situation, you can change the stimulus size and make it bigger. Also, the refraction. If the refraction was not used, then it's an area for you to look for if there was a refraction used or not. And then based on that, you can say whether this is okay to accept, or you should go back and have them wear their prescription and then get another information. Now, on the upper right corner, you have here the threshold of the test, or the strategy of the test, Central 24-2 threshold test. And then you have the date. The date is important, and also the time is important. And then the age, as we said, date of birth, and now the age, because the age, you can see it on 2 different areas to make sure that they match the age. And why the time is important, because let's say you bring someone and then you get this clover leaf pattern. That means the patient fall asleep in every test you do. And then you ask them, why are you falling asleep every time I bring you? They say, well, doctor, I've been living for years. I sleep maybe 5 in the morning, and I wake up at noon. That's my life. That's how it is. And you bringing me at 9 a.m. and you asking me to be attentive. I can't do that. Then you say, okay, then now we're going to bring you back in the afternoon and do it when the patient has a better ability to perform the test. Okay, now we're going to move on to Grayscale, and now we finished the top part and labeled everything, and now we move down to the Grayscale and what's facing it, the numerical scale. The Grayscale is more of you will see a scotoma here on the Grayscale, but it's more of a patient information and explaining, more than using it as a clinician to diagnose and make judgments. It displays the scotoma in a more obvious way that can be easy to explain to the patient. Now watch with me here. This is a 24-2. But you see the field is marked, you see it goes everywhere. It tests out up until 24 degrees everywhere except nasally. Nasally, the machine will extend a little bit more towards the nose and test up to 30 degrees to the nasal side. This is helpful particularly in glaucoma patients, because we know most of the early visual field defects in glaucoma are nasal steps. So this will ensure that we're not missing a nasal step. And also it helps you determine the orientation of the visual field. So this, wherever the points go all the way to the 30 degree, that's where the nose is. If you see a scotoma here, that's a nasal scotoma. This is the blind spot. Some of the grayscale, you don't see the blind spot. Why is that? Does that mean the patient doesn't have blind spot? No, of course, every patient has a blind spot and they have an optic nerve. But for a very small optic nerve, the area of the optic nerve is too small to be tested. So it falls between the two testing areas and it doesn't appear as a blind spot. So that's why you see some grayscale without a blind spot. And then look here at the grayscale, at the numerical scale. Now, remember, yes.
Would you please repeat the point that sometimes we don't see the blind spot? Why we don't see it?
Yeah, so you know why we see a blind spot from the beginning. We see it because that's the area where the optic nerve is, where the optic nerve insertion. There is no rods or cones there. It's just no. Yeah. So when the light is being projected to the optic nerve, it will appear an absolute scotoma because there's no rods or cones there. And then what's going to happen? In a very small optic nerve, remember I told you that in the Humphrey visual field, it tests between 1 to 4 degrees. Every 4 degrees, it would test a point. That's how it determines the blind spot. In people with a very small optic disc size, it will test first point before the optic nerve and the first point after the optic nerve. So it will miss that point and will mark it as normal.
Yeah.
And in this one, looks like the patient had an average size optic nerve. So we see a blind spot. So look at the number, numerical value in where the blind spot is 0. And as we said, it ranges between 0 to 50. Anyone start testing 40 or above, think of a trigger happy patient. They keep on clicking and they want to get that information as much as possible. So it's not reliable. Normally, you see more numbers in the center than the periphery. So look at the center. You have 34, 33, 32, all these numbers. That's very normal. This is where the average normal is. And then when you go to the periphery, you see less. See 27, 29, 27 there, 28. So so this is how we look at it. Now, you may hear about something called split fixation. You know, in people with advanced glaucoma. When you hear the term or the terminology split fixation, when you go to the 4 areas that's been tested by early in the visual field to determine the patient's fixation points, if they test less than 10 in these areas, in one area and the neighbor area, at least 2 of them less than 10, that's where the patient has fixation split or split fixation, and those are usually very symptomatic. That's when you see that number on the visual field, the machine, and then you ask the patient how you feel. They say, you know, doctor, I think my vision is getting worse. I think I'm getting. That's a very bad sign. And when we see that, we usually need to do something rather quickly than, you know, let them, you know, keep losing it. And we're going to go more into that in a few slides. Again, remember, whenever you see that triangle, that's where the nose is. It helps you for orientation and also helps you for, you don't even need to look at which eye. You can tell from this that this is a left eye. And I'll show you the orientation, how we should read the visual field. Now, again, this is just, sorry, that's just a repetition. Okay, here. Now we moved, we finished the grayscale and the numerical scale. Now we're moving down to those 4 plots here. Those are called, we have total deviation in, you know, in pattern and also numerical. and we have total deviation plot and pattern deviation plot. By far, those two are the most important. That's where the doctor look and give the right information about whether this is glaucoma or not, whether this is a cataract or media opacity or refractive error or whatever. So those are the areas where we look down and analyze our results, not the grayscale up there. So total deviation, when you see a visual field defect on the total deviation, it tells you that there is a problem. Okay? There is a problem. We don't know whether this problem is cataract, glaucoma, corneal opacity, uveitis. We don't know. It's just there is a problem. That's what total deviation tells you. And then what it does, it just looks at the visual field as a overall. Like overall, there's a reduced sensitivity, a general sensitivity, but it does not point out the real loss versus the loss that's coming, or the reduced sensitivity coming from the media opacity or other things going on. And it's more specific when you have a patient with glaucoma and a focal visual field loss and cataract at the same time. So this total deviation will become all black. And then you move on to the pattern deviation. What the pattern deviation do? It will bring the hill of vision down and try to see which area is a real loss versus just a reduced sensitivity. And that's where you take your glaucomatous scotoma from here, from the pattern deviation. So again, in a simple term, total deviation assess the whole thing. Pattern deviation is more specific into focal loss and real loss. And then down here, we have something called global indices. We have glaucoma hemifield test. Remember this, glaucoma hemifield test, we're going to be using it a lot. And here in this normal test, of course, it says within normal limits. I'll give you the all the options what this glaucoma hemifield test will come as a comment. VFI, or visual field index, it will give you a number. This is it's not very accurate in quantifying what visual field the patient has, but it's an easy number to communicate with the patient. If you have a patient with visual field, they'll say, how much visual field I have. You can tell them you have 100%. But sometimes they come with advanced stage glaucoma and you see 50%. They ask you, how much visual field I lost so far? So you can read off that number. You can say, well, your visual field index says that you have lost 50% of your visual field. It's helpful in a communication way, but not in a very accurate assessment of what's left in there. And then you have the mean deviation and the pattern standard deviation. The mean deviation is also remember we talked about the total deviation and pattern deviation. Like mean deviation is also is similar to what total deviation plot is, and pattern standard deviation is similar to what PSD, or pattern standard deviation, is similar to the pattern deviation plot. But this is in numbers, this is in shapes, in a graph, to see that. So the mean deviation will match each point to a normal to the age of that patient. So it reflects, diffuse changes. It is a cataract. There's a problem happening, but we don't know what it is. We don't know if it is a permanent or something, just a media opacity or refractive error, but there is a problem. Now PSD goes and goes way deep into it and tell you, oh, okay, we have a focal loss. Corrected pattern standard deviation is the same as PSD, but sometimes we have to correct for pattern standard deviation to confuse you more. As the glaucoma progresses more, sometimes the PSD improves, and you may wonder why. By the way, this is a Royal College exam. They love this. You know, you have advanced glaucoma, but pattern standard deviation is becoming better now. Why is that? Because pattern standard deviation will evaluate a non-localized or a non-localized lesion. Like it will go up as we say more localized lesion. It is not good to have like a uniformly bad field. It will give us a good number. Let's say the visual field is all bad all throughout. There's no focal loss. The whole thing is bad. Then the PSD will improve because it's planned that way. It will give you a bad number if it sees a localized lesion. But if that localized lesion continues to progress and becomes the pattern, becomes the whole thing is bad, then it will give you a better number. So that's why we need to correct that.
So, Dr. Gdih, we can say that the PSD describes how much homogeneous is the pattern.
Yes.
The more homogeneous, the higher the PSD.
That is correct.
Mm-hmm.
Yeah. The more homogeneous the defect is, the better the PSD will be.
Yeah.
And then that way it will give you wrong information. So that's why we need to correct for that. And by the way, when we're going to talk about the criteria of Anderson in diagnosing glaucoma, we can use either one, the one that you have available. So they can use alternatively whatever for that patient it was used. Okay, now back to the glaucoma hemifield test. Remember that GHT? So GHT, the machine will give you one of these 5 sentences, nothing else. There's no sixth one. Okay, it's either going to say within normal limits, or outside normal limits, or borderline, or general reduction of sensitivity, or abnormally high sensitivity. The one that the two most important we need to know is whether it's normal or outside normal limits. Those are the ones we're going to use in our criteria. How does the machine come up with this comment? It's basically comparing areas in this pattern deviation plot. Area 5 to area 5, area 4 to area 4, 2 to 2, and 1 to 1, and 3 to 3. It will compare them, and based on that comparison, it will give you this information. And we will see some examples on that in our testing, in our exercise. Okay, and now we're done with the global indices. Now we're going to go down, and probably the last one is the Pvalue Index. Now we need to use the P-value for these, the P-value of these points, by the way, on the deviation, on the total deviation and pattern deviation plots down here. We have an index so that we don't have to memorize which one is which P-value is less than 5, and which is less than 2, and which is less than 1%, and which is less than 0.5%. So we have it always ready for us on every printout, so we can reference back to it and look which number we have here. So for example, this single dot here, what P-value it is? Looking at the scale.
Less than 1.
Exactly, less than 1. Yeah. So the less P-value, the more visual field depth is, like the more deep the scotoma is. So a full square will give it a P-value of less than 0.5%. And a square with a few points missing will be less than 1% P-value. A square, but a lot of dots missing to make the square will be less than 2%. And only 4 dots to outline a square will have the least. This is like the least scotoma, which is P-value less than 5%. Okay, now we're good with every single section of the visual field. We're going to move to orientation. How do you orient a visual field before you read it? You want to bring the right eye in front of your right eye, the examiner, and left eye in front of your left eye to examine, and you read it as is. So if I see now, this is where my nose is for the in relation to my right eye, and this is where my nose is in relation to my left eye. And you could see here the areas has been tested all the way out to 24 degrees everywhere except where the nose is. It extends to 30 degrees. And both peaks are pointing to each other. That's how you orient it. Okay, how to read a glaucomatous visual field. We have 3 rules. Okay, we have 3 rules to apply before we go ahead and read a visual field. Rule number 1, always correlate the visual field with a glaucomatous optic neuropathy. You cannot say, okay, here I have a superior arc width, and then you look at the optic nerve with a very healthy rim and 0.3 CD ratio. Okay, where did the superior arc width come from then? Right off the bat, right there, you cannot proceed. You just have to think something else. So you always have to correlate the visual field results with the glaucomatous optic neuropathy. Okay, now, since we said glaucomatous optic neuropathy, let's see what they are, what these glaucomatous optic neuropathies are. Increased CD ratio or disc asymmetry, rim tissue integrity. If you have inferior or superior notch, temporal thinning or slope, if you have a central pit or inferior or superior optic nerve pit, if you have a violation of isn't rule, just as a reminder, it stands for inferior, superior, nasal, and temporal. And it by nature, the neuroretinal rim tissue normal thickness pattern is in the term isn't. Inferior being the most thick and temporal being the thinnest normally. But if you see a violation of that, you see the inferior rim is thinner than the temporal rim, then there's a violation right there. So that brings up the suspicion of glaucoma. And then visible lamina cribrosa, trans or disc hemorrhage, nasalization of blood vessels when the blood vessels shift to the nasal side, or bearing of blood vessels, those circumlinear blood vessels, when you see them, they become more visible there because of the RNFL being, atrophied. And then bayoneting of blood vessels. And that means the blood vessels are kinked in a very sharp pattern, like a bayonet, bayoneting, like the knife, the bayonet. Rule 2, so we said rule 1, always correlate a visual field to a glaucomatous optic neuropathy. Rule number 2, visual field defect should follow a pattern of RNFL loss and should be located in an area that is common for glaucoma. What does that mean? There are certain areas that's common for glaucoma in the visual field. If it is not one of them, you cannot take it right away. You should look back and repeat the test, and you have to make sense of it. So what are these areas? So nasal step, as we said, it's being the most common. You can have a temporal wedge, less common, but it's a temporal wedge, you can have that. Or superior or inferior arcuate scotoma. You can have an early a paracentral scotoma, either superior or inferior. You can have a paracentral scotoma that's more threatening fixation, and that's more so in low tension glaucoma, where they tend to be, the scotoma tend to be deeper and closer to the center. And then superior arcuate with some extension, or inferior arcuate. Tunnel vision with like a central island left or temporal island, or end stage glaucoma where the whole field is lost. So really, if you think about these patterns, there is no additional pattern. You know, you think about it, there is no additional pattern. So rule number one, we said it has to be make sense. It has to make sense from an optic nerve standpoint. It has to make sense on the printout that's in an area that's common for glaucoma. And then it has to be non-glaucomatous too. Like, so what are the non-glaucomatous? If you see an enlarged blind spot, that's usually not glaucoma. Or if you see a hemifield that's very sharply demarcated and lost half of the visual field, like left or right homonymous hemianopia, you know, that's more of a central nervous system problem, like a stroke. Or if you have a bitemporal hemianopia loss, that's more of a pituitary or supracellular lesion. If you see a macular, if you see a central scar, that's not usually common, like the whole center occupied, that's more of an AMD related or macular disease. If you see a very peripheral upper, not connected to anything down there, that's more like an lid artifact. Centrocecal, you know, like a blind spot connected to the center, more of a toxic optic neuropathy. If you see spiral, like something doesn't make sense at all, like there is no pathology that can give you a spiral like this. So you think about malingering and hysteria. Okay, rule number 3, visual field defect now should meet the Anderson's criteria for minimum glaucomatous visual field loss. Now, when we say this minimal glaucomatous visual field loss, you can have more than that, but this is the minimum to call this glaucomatous. And I want everyone to understand that, you know, if you don't have a glaucomatous visual field, it does not mean that you don't have glaucoma. There is something called pre-perimetric glaucoma, where a person will have glaucoma, but they have not lost their field yet. So we cannot just you know, learn this and then apply it. When apply it, we have to apply it properly, because we cannot say, okay, this is a non-glaucomatous visual field, so the patient doesn't have glaucoma, no treatment. But we look at them, they have already enlarged cup-to-disc ratio, they already have a strong family history, three brothers went blind, and their pressure is 35. But when you test their visual field, it's normal. We cannot ignore that. So there's something called pre-perimetric glaucoma. So just as a reminder, we cannot use this to exclude glaucoma. We use it to diagnose glaucoma and diagnose visual field that's caused by glaucoma. Visual field defect that's caused by glaucoma. So again, I want everyone to take a screenshot of this. This is what I want you to keep in mind, or put in a sticker behind you to follow this pattern whenever you're interpreting a visual field defect. So you have a visual field defect. You're going to look at it. First question you ask yourself, does it correlate to a glaucomatous optic neuropathy? Yes. Okay, now we move down. Is this visual field localized in an area that's common for glaucoma? Is it an area where, like an arcuate or a nasal or paracentral, is it following these patterns? Yes. Okay. Now let's apply Anderson criteria. Is it applicable? Yes. Then yes, glaucoma. Then you have no problem saying that. Now again, this is something else I would like maybe everyone to take a screenshot of. These are the 3 points of Anderson, who identified the minimum to have to call this glaucoma. So look at the color code here. Number 1, look at the green circle. 3 or more non-edge adjacent points in an expected location in the central 30 degrees of field that have p-value of less than 5% on pattern deviation plot, one of which must have p-value of less than 1%. They're talking about these points. They have to be non-edge. Non-edge means this 1, 2, 3, 4, 5. We cannot count. Those are out of the count. Those are edge points. They are on the edge of the visual field plot. We count the ones that's inside this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. We have 16 adjacent points. See that? Non-edge adjacent points. We cannot count those 2 points here, which are non-adjacent. Why they're called non-adjacent? Because they have a normal points in between them. So we cannot count these 2. Is my cursor clear to you when I'm moving it?
Yes. Yeah, it is.
Okay. So these 2 points, even though they are part of the, scotomatous, they marked as a scotoma here with a p-value of less than 5%, but we cannot count them among these points here. Now, all of these points must be less than 5%, which is this one here. They all have to be less than 5%. Okay, so is this dark one, is it less than 5%? Yes or no?
Yes, it is, of course.
It is, because it's less than 0.5%. So that anything that's less than 0.5 is less than 5. So all these points are counted. We need only 3. We don't need 15. We need 3. So we have more than what we need. So for number 1, from Anderson criteria is a check mark. Yes, we have it. Okay, number 2 is easy. GHT. Look at GHT. Glaucoma hemifield test. It should be marked as outside normal limits. Does it say outside normal limits here?
Yes.
Yeah, right. So check mark. We have 2 now. Okay. Now we're gonna move to the third one, to the blue. CPSD or PSD. Remember, I told you the machine could use either one of these, or even both. So whatever you have, the p-value of PSD, just take the p-value right there. What does it say here? The p-value less than 0.5%. Is that less than 5%? Yes. So we have a check mark here. So for this particular visual field, all of it does follow, and the Anderson criteria is applicable. So it is glaucomatous. Okay, so time for some exercise now. Okay, let's pull the example number 1.
Okay.
Do you want to take it, Dr. Mazen?
Yeah.
Okay.
Actually, yes, it is, because we have 3 adjacent point, non-edge.
Okay.
And we have outside normal limits. And the P of the PSD is less than 5%.
Perfect. So yes, I agree with you. We have more than 3 non-edge points with p-value less than 5% on pattern deviation plot, and one of which is less than 5%, less than 1%. We have GHT outside normal limits. We have PSD less than 5%. We're good. This is glaucomatous. What type of pattern is it? I mean, just name it. Give it a name. How does it look?
Arcuate?
Yes,
arcuate.
It's a superior arcuate. Yes.
Yeah.
And in a superior arcuate, we expect to see an inferior notch in the optic nerve head. So in this patient, they have either an inferior notch in the optic nerve or inferior pit, and it's reflecting. Everything is opposite in visual field. Whatever you have in the temporal thinning or notch will show you a nasal step. Inferior notch will show you a superior arcuate. Superior notch will show you an inferior arcuate on visual field. Everything is opposite. Okay, example number 2. Yes.
Just quick question regarding the previous field, the previous example. From your experience, how can you differentiate between like proper visual field defect in this case and the upper lid effect?
Correlation, always correlation. Like I agree with you. I mean, okay, so one thing with the lid artifact you will see is that they're usually not connected to the blind spot. Okay, so that's one thing. By definition, the arcuate scotoma should extend from the nasal step all the way in an arcuate shape and connect with the blind spot. Sometimes you see a comment that says pending inferior or superior arcuate. You see a visual field that extends from the nasal step in an arcuate shape, but it goes all the way up to here and it doesn't connect with the blind spot. So we call that like a pending inferior arcuate or a pending inferior arcuate. In an artifact that's caused by a lid, you will not see it connected to the optic nerve. You may if the upper eyelid is too droopy, but you will notice that clinically, and you would have screened that already. Remember that slide I showed you? Does it make sense? And go. If anything missing from these steps, you're not going to go further. You're not going to call this or give it any significance before you address the other things.
Thank you.
You're welcome. Okay, example number 2. So, okay, let's do it together. The first point, do we have 3 non-edge points? Okay, we have 1, 2, 3, those are edge. We cannot count them. We have 1, 2, 3, 4. We have 4, so we have more than what we need. And it's in the nasal aspect, so it's in an area that's common for glaucoma. And GHT, is it outside normal limits?
Mm-hmm.
Yes, it is. And then PSD, less than 0.5%. So we have check mark here, check mark there, check mark there. Glaucomatous, this is a nasal step, upper nasal step. Let's look at this one. See, we have like a scattered visual field losses here.
Yeah.
And they kind of repeat here, but denser on the pattern deviation. But let's see if it is significant or not. Okay. First of all, do we have 3 points? 1, 2, 3. We do have a cluster of 3 points. Does the p-value of all of them less than 5%? Yes.
But none of them is less than 1%. None of them.
Exactly. So we have lost it right there. How about the glaucoma hemifield test? It's
normal.
Within normal. We lost another point. And CPSD, what does it say here? Or PSD, sorry.
Less than 10.
We lost, right?
Yeah.
So loss. So even if someone comes to you and say, oh, could be glaucoma, say no, it's not glaucoma. I mean, again, I'm saying, visual field language, not clinically,
Yeah.
As I said, clinically, you could have someone with a totally normal visual field, but they have glaucoma.
Yeah.
Okay, now let's move on. We'll take this example now. First point, let's count. Those are edge, we cannot count them. So we have 1, 2, 3, 4, 5. So we have more than what we need. This one we cannot count because it's separated or surrounded by normal areas, so we cannot take it into account. And then it's repeatable on total and pattern deviation. And GHT, outside normal limits. PSD, less than 2%. Then we have check mark here, yes, 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 it is glaucomatous, inferior nasal step.
Great. Dr.
Yes.
Right, one more question. For the gold standard, as you said, from my understanding from what you said, it's always the standard. So with this one, for example, criteria be applied in these cases?
Dr. Munir, would you please repeat? We couldn't hear you.
Yeah, you were cutting off.
Sorry. Yes, sorry. I meant, the gold standard for the Humphrey is usually the standard CETA. So like with this example, It's the fast CETA. Would that still, I mean, the same criteria be applied?
Yes, yes, same criteria. Yeah, you're right. Yeah. Good point. Good attention. This was used CETA fast. CETA fast when you have a problem with the reliability of the patient. You keep bringing them unreliable. You can't get any information. But you put it on see the duration of the test, 3 minutes. This patient's like patients who cannot sit still. So we have to use that, not by choice. You have to get some information.
Perfect. Thank you.
You're welcome. Okay, let's look at this example now. Example 5, we have. Okay, look how bad the total deviation is, and look at the pattern deviation. It's improved a bit. So this could tell you that this patient has glaucoma and cataract at the same time. So this part was affected by cataract, like uniformly affected, and then now it's been localized and highlighting the areas that has a real loss. Okay, so do we have points? Now it's become easy, right? So we have more than points we need, right?
Yeah.
GHT outside normal limits. PSD less than 5%. So they all check marks. Yeah, so this one is with like an inferior arc width with upper paracentral scotomas and with probably some fixation losses. See, they're almost going to lose fixations. Look at the number there, 11. So they're getting very close to split fixation. Okay, let's look at this one. Look how terrible their gaze tracker is.
Yeah.
Look at that. Up and down, up and down. Look. And then look at the fixation losses. 9 out of 11.
Yes.
Yeah, I brought it anyways, and it does show here. Like the machine will tell you low test reliability. It will mark it down there. Sometimes we'll put a comment, just to tell you. So for the 3 non-edge points, do we have them? Yes, we do. Right? Is it in the area common for glaucoma? Yes, it's in the nasal aspect. Is it outside normal limits, GHT? Yes, it is. And PSD less than 0.5? Yes. Now, every unreliable field, we cannot throw it away altogether. Okay, so that's another important point. We cannot say, oh, this is not glaucoma because it has fixation losses, and we can still obtain information from that, but it might not be ideal to make decision based on it. Like you cannot say, okay, this is worse compared to last time. Or you say, okay, there is a progression right there. So that's where you need the reliability more, and you may want to repeat that. Example number 7. Okay, let's look at this. This looks very bad. It looks like a patient with advanced glaucoma, but no cataract, okay, right? Look at the total deviation. They probably have 20/20 vision, okay? Because in these cases, they usually spare their visual acuity, like the central acuity, but they have a terrible visual field. They have upper and lower visual field defect. Let's look at the criteria. Do we have 3 points? Yes, we do. Do we have GHT outside normal limits? Yeah, we do. How about CPSD or PSD? It is less than 0.5%. Then we have check mark for all. It is glaucoma, and we call this double arc width. If you look at this patient, you may find like a superior notch and inferior notch. So they are vertically, the optic nerve is vertically elongated. The cup is vertically elongated. Now look at the VFI. Remember I told you the patient may ask you how much field I have lost. So you can look at it and you say, you know what, you have lost, more than 40% of your visual field. Even though if we look at it now, if we look at this like what occupies this. This is more than 40% of this particular field, but it doesn't represent the actual field of the patient. They have more than that. So that's why we have to determine their, driving ability with a different field that gives you a better range of visual field to tell them whether or not they can drive. Okay, let's look at this one here. So from the criteria standpoint, 3 non-edge points, do we have? Yes, we do.
Yeah, yeah.
GHT outside normal limits. CPSD or PSD with less than 5%. Yes, they all fit the criteria.
Yeah.
Another very bad field here. Let's have a look. See, as now we progress into the field examples, it becomes easier. We know where to look now. Like we're going straight to this pattern deviation, looking how many points we have. Yes, we do. GHT outside normal limits. Yes, we do. PSD less than 5%. We're good. All 3 points are checked. So it does fit the criteria. Okay, now look at this one. Like, look at this bad field here. Look at pattern deviation here. Terrible. But does that mean this patient has glaucoma? Or is this real? Why total deviation? Why total deviation is so nice and clear? Look at this.
Yeah, and in addition, some of the values are above 40. This is why there is white area.
Exactly.
Yeah, unreliable.
Yeah, see where the white scotoma is? Look at the numbers there. 45, 47, 48. It's like high numbers. And then look at this. Look at GHT. See, it didn't give us outside normal limit. It said something else. It says abnormally high sensitivity. Okay, so we'll go back to the points now. Now back to the points, we have, do we have number 1? Yes, we do, strongly. We have number 1, a lot. And then do we have number 2?
No.
PHT? No, we don't. How about number 3?
Yes.
We do. Okay, so we have number 1, we don't have number 2, we have number 3. See, we missed only 1 point, it's non-glaucoma.
Yeah.
Done.
Now, one of the audience says that maybe it is blink with a question mark. I think you said, Dr. Gdih, that if it is blink, then the lines should go down.
Correct. Yes.
The graph, inferior graph, it should we should see lines downward, right?
Yes, that's right. Yeah, this is a trigger happy patient. They kept on clicking multiple times. They click like when there is stimulus and when there is no stimulus. So they just keep on clicking to get every point possible. So yeah, they could be just normal. They're just nervous and normal. Okay, let's look at this one. Do we have 3 points? Let's count them. We have 1, 2, 3, 4, 5, 6, 7. And yes, it does fit the criteria. GHT outside normal limits. CPSD or PSD less than 5%. Yes. So we have them.
Just a second. It shows less than, but for the first one, the 3 non-edge points, they should be in an area where we expect that it is glaucoma, but here it is central. Do we expect that?
Good point. Yes. Well, like this, it could be glaucoma. It could not be. It could be glaucoma if you have a low tension glaucoma with a central pit. You know these acquired pits right in the middle of the optic nerve. It can give you something similar to this. But also, again, we should go back to the. It is still possible glaucoma. We should go back to our tree that we follow. If we see something, you know, correlating to this in the optic nerve, and we go through this, then yes, we can, the criteria would be right. Yeah. Okay, let's look at this. See how bad this total deviation is, and see how good it is on the pattern deviation. If this patient has glaucoma, it's got to be like, you know, a small defect there, but they have something else going on, which is either refractive error or, you know, the patient is hyperopic, you can see that. Or they could have cataract or something else. Okay, let's go.
There is less of fixation, 14 out of 14. Wow.
That's right. And the gaze tracker was turned off. See, we don't have it here. Okay, so let's go over the points. Do we have enough points? Let's count them. We have 1, 2, 3, 4, 5, 6. We have enough points. How about GHT? It's outside normal limits.
Outside limit.
And CPSD less than 1%. So we have all the points actually.
Yeah.
It could be glaucoma, but again, fixation losses, yes. And now just one more point I'm going to say about the fixation losses. Again, we cannot throw out a visual field totally because they have fixation losses. What does the fixation loss mean? At that time where the machine is testing for whether the patient is fixating all the time on the test, it will be testing like peripheral points, and then all of a sudden we'll go back to the area where the optic nerve is, or the blind spot, and it will give a stimulus there. We'll see. Let me see if this patient is still attentive. And if at that particular moment they were looking away and they didn't see it, it will mark it as fixation loss. But they could have looked away at that particular time and then went back and did a good test after that in between. So we cannot throw out everything, especially if it is clinically correlated. Is that clear?
Yes.
Okay. Let's look at this one here. Do we have 3 points? 1, 2, 3, 4, 5, 6, 7. We have 7 points. That's our non-edge. GHT outside normal limits. And we have PSD of less than 5%. So they all correlate. See, this is theta fast as well. Because there is a problem with reliability. Okay, let's look at this one. Do we have 3 non-edge points? We have 1, 2, 3 edge points, so we cannot count them. We have 1 single that nothing around it, and we have 1 single there, nothing around it. So we don't have a number 1 is missing. GHT, do we have it? Outside normal limits. So we do have GHT. Do we have PSD with less than 5%? No, it's less than 10%. So we lost there, we're check mark here and lost there. So you can tell this is not glaucoma. Okay, now here are some examples when it looked like glaucoma, but it's not. Okay, so look at this visual field. Do we have points? We have 1, 2, 3, 4, 5. We have a lot, right? GHT says outside normal limits, right? PSD less than 0.5%. Is it an area common for glaucoma? Absolutely, right? Superior arc width. Okay, so why it's not glaucoma? Because when we looked in the fundus, we found this optic nerve coloboma. Morning glory.
Yeah.
Yeah. Okay, let's look at another one. Let's count how many points we have. 1, 2, 3, 4, 5, 6. We have a lot. GHT outside normal limits. PSD less than 0.5%. Is it an area that's common for glaucoma?
Yes.
Yeah? Okay, is it glaucoma? We don't know. Let's look at the fundus. Look at this. toxoscar, chorioretinal atrophy, optic nerve totally fine. That's why correlation, clinical correlation is like number one. Okay, let's look at this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have more than needed. GHT outside normal limits. PSD less than 5%. Is it an area common for glaucoma? Yes. Inferior paracentral. Look at this. Retinal vein occlusion. Okay, now this is a case presentation. This is a case was sent to me for consultation. She's a 76 years old Caucasian lady, referred for a blurred vision and for possible cataract surgery. Her past medical history was only remarkable for a mild hypertension with very good control. On ocular examination, her visual acuity was 20/40 on the right eye and 20/30 on the left eye. Her intraocular pressure was 14, both eyes. No RAPD noted. On slit lamp exam was a trace nuclear sclerotic cataract, otherwise unremarkable. Everything looked normal. On fundus exam, I noticed temporal pallor with 0.6 cup to disc ratio on each eye. The discs were symmetric and that pallor was symmetric and nothing else was concerning except a little bit of elevated cup to disc ratio, but the rim was intact. So I thought, okay, this could not be just a cataract. And before we go ahead and remove the cataract, let's order a visual field. This is an example where the visual field can be a lifesaver. Okay? So this is her visual field. So I put them together, right and left, in the orientation that you need to see it. So first, what do you notice, Dr. Maza?
I noticed that the left eye, no, sorry, the right eye, hemisphere. It is not passing to the other side. It is hemi field, let's say.
Yeah, so it's respecting the midline. Yes.
Yeah, respecting the midline, and I think this is something called junctional scotoma related to optic nerve tract something.
Okay, so let's look where the visual field defect is happening. It's right now the visual field is oriented the way it should be when you read it. So the defects are on the temporal aspects, right?
Yeah.
Look at the nasal aspects. They're nice and clear on both sides. There's no nasal defect on both of them, on the both temporal sides. So she has non-congruous bitemporal hemianopia. Okay. So first thing you want to do, what do you want to do?
MRI.
Imaging, right?
Yes.
Like for imaging.
I think this is.
Yeah.
Exactly. Yes. Pituitary. Yeah. Exactly. That's it.
Yeah. So I sent to neurology because with this visual field defect and the suspicion and all, just for for the sake of time and everything, I don't do myself the MRI and order, and then she had to go back to the neurologist and they will order a different strategy. We say, يعني أعطي الخبز الخباز. We let them do it. Okay, so I sent her to neurology. They ordered MRI and they found large pituitary macroadenoma that was causing her to have a blurred vision. And by the way, while she was waiting for the MRI and the consultation, everything, she got actually worse, and her vision started to deteriorate even more. So soon after they found that, they sent her to neurosurgery, and then the tumor was removed in a very short time. Okay, so she returned back to me for follow-up. Now her visual acuity is 20/25 right eye. It was 20/40, and she was 20/20 left eye. Now she improved. Subjectively, she's fine. She feels, her vision is better, and she doesn't need cataract anymore. So now cataract is mild and to be monitored, and there was no glaucoma that's of a concern, and patient is much happier. This is her post-op field. Look at that. This was just a few weeks after the surgery. She hasn't even recovered fully yet. You may say still there is some visual field defect. Yes, I agree with you, but let's put them together and then you can look at that. See, this is the pre-op. Her right eye was worse. So look at the right eye, much improved. And then look at the left eye, almost nothing, just a peripheral defect there. And you look at the VFI, visual field index was 66% in the right eye, improved to 82%, and then 79% pre-op improved to 93%. So again, this is what we should follow. Visual field defect. If you see it, correlate it with the glaucomatous optic neuropathy. If the visual field localized in an area that's common for glaucoma, then move on and apply Anderson criteria. If it is applicable, then you can make the diagnosis of glaucoma. Take-home message: use CETA standard 24-2 Humphrey visual field test for your glaucoma patients in both diagnosis and follow-up. Use CETA fast when you cannot get the patient to produce a reliable test. Use 10-2 and/or size 5 stimulus in advanced stage disease or when you have a reduced visual acuity. Patients don't generally make up glaucomatous visual field defects. Those patterns that we looked at and we learned and we saw them in all these examples, patient cannot intentionally make those happen. Those are a pattern in the RNFL that if they are there, they are real, even if the test is not reliable. Okay. Repeat when in doubt. Glaucoma is generally a very slow disease. You do have time. So repeat, repeat, repeat. As Dr. Tariq Sharawi said, throw away the first two, and I agree with him. Be attentive to your patient's limitation in performing visual fields and count for them. What limitations we talk about? People with difficulty coming up to the chin rest. People have scoliosis or neck problems, rheumatoid arthritis. They might not be able to put their chin on the machine properly, and you may see like an artifact here and there. People with a very small, the refractive error, the pupil size, all that things we talked about. Apply Anderson criteria, but in certain cases, keep the suspicion high if the criteria are not fulfilled. Again, I told you there's glaucoma. This lecture is meant to read the glaucomatous visual field. It's not meant to make a diagnosis of glaucoma or not, because you could have glaucoma with a completely normal field. Visual field test can be a lifesaver in some scenarios, like this lady that I presented with a macroadenoma. Thank you very much, and welcome any questions.
Thank you very much, Dr. Gdih. Actually, that's wonderful. This is the first time I understand interpretation of visual field. Believe me, this is the first time. And one more thing, I was thinking that the only beautiful thing in the eye is interpretation of tomography, because it is full of colors, and why the visual field is just like black and white. I hate it. Now I discovered that the interpretation of visual field is more beautiful than interpretation of corneal tomography. So thank you very much for simplifying the matter. And it is like fast food, but it is healthy food. Thank you very much.
You're welcome.
That was a wonderful presentation, Dr. Gdih. I personally learned a lot from this. Thank you very much. Really, really nice.
You're welcome. Okay.
One of the questions, can we apply the same rules on octopus machine or only the Humphrey?
Yeah, good question. The octopus, unfortunately, most of the studies that were, like the early studies that were done on the Humphrey machine, not the octopus. However, many points are very similar. And I would say yes, the least that you can do if you have only octopus is to apply these points to the Octopus machine as much as you can. I have no experience with the Octopus, and I don't use it, to be honest. But I sometimes face a patient that comes with me with a field that was done elsewhere, and they ask me to look at it, and I look and I find very similar points. So yeah, the answer is yes, you can apply those points to that, but to be clear, these points are derived from the Humphrey visual field, not from the Octopus. Octopus is, I believe it's a Hogstrite, company, and this is a Zeiss. So they're different in their principles. They're the same, but the criteria that was driven is from the Humphrey, not the Octopus.
Dr.
Actually, yes, Dr. Munir, please go on.
Can I just add a couple of things which we do in our center here in Coventry? So we abandon, or we don't do any fields for any patient above the age of 90 because of the factors which you mentioned about the age. So that's the standards in our center, and we do Goldman instead if needed. Obviously, most of the time is not needed, especially if this is stable-ish. So we don't do any, but we don't do any Humphrey above the age of 90 because it's, as you said, the sensitivity and the factors related to the age. The other thing is any patient who's already using pilocarpine eye drop, we usually advise them to stop it 3 days at least before the day of the field to be able to get reliable visual field, especially for, like, let's say a patient who are slightly myopic, a young patient. So those patients, you won't be able to get, as you said, good sensitivity and good outcome with the pilocarpine. So the minimum in 3 days. And lastly, again, as you said, with the refractive error, especially people who are very myopic, we prefer always to do it using the contact lens in situ rather than the correction because of the rim effect. So it's always, we get much better outcome with the contact lens in while doing the field. Lastly, obviously, it's the visual field index. As you kindly mentioned, it's a kind of one of those criteria which gives us an idea about the function, the visual function. But in my experience and what I found, again, according to the literature, it can be affected mostly if you have central visual field defect. And that's mostly, like, for example, if the patient has macular disease, so you see the visual field deteriorating very quickly compared to scotoma. Peripheral scotoma won't affect the visual field index as such. It's mostly any visual field defect in the central area that can be very, very sensitive for this. So, yeah. I don't know. What do you think about the visual field index? Do you usually check it along with the mean deviation, or you don't usually? You are not very interested in this.
No, as I mentioned, the visual field index is not very accurate number that reflects how the patient is doing. Sometimes you can have it quite high in a very advanced disease, and vice versa. You can have it lower on someone with, as you said, with a central dip in the macula. That they have like a very mild glaucoma and very poor visual field index. So again, as I said, it's something, there is a diagram. It will give you like the VFI and then the expected drop in VFI over the years. So it helps me tell that or show that to the patient. We say, in these last 5 years we lost this amount. And if we project your 10 years from now, depending on the speed of your glaucoma, we might end up here. It's a tool to communicate with the patient. That's all what I use it for. Yeah. And it's not even a good one for glaucoma progression. Like if you look at it, it's not a good one to. We haven't talked about progression, by the way. Progression analysis is more of a. That's like that needs another 2 hours like this.
Oh, thank you.
But for this one in particular, I wanted to help people how to, when they hold the visual field, to make sense of it and what to look at when they're going to read it quickly. If someone shows you a visual field and say, what do you think? And then, okay, I think this and this and that.
I think you definitely succeeded in this. Thank you very much.
Okay, if you don't mind, Dr. Maz, I'm just going to go through some of the questions here on the panel.
Okay.
What is the cutoff of visual acuity to do a harm-free visual field? I would say 2200 is the cutoff for visual acuity, which in your British system is 660. Munir?
Sorry, I didn't understand the question.
The worst visual field, the worst visual acuity that you will perform a visual field test.
Yeah, I don't usually do 618, 6/18 or less. It's usually unreliable.
Okay.
But you can always try. You can sometimes try up to 624, but 618 or less usually it's the borderline.
Yes, exactly. Okay, someone said, how about phobia off and on? We answered that earlier. In my experience, yes, I do set the phobia off. You know, someone said, is it better to set it off? I do, because it's an extra tool to monitor for fixation losses, and it can give you a lot of unreliable fields, even though they are reliable. Can be a case of hypoplastic optic disc.
Dr. Gdih, stop sharing, please. I would like to show you something, show the audience something.
Sure.
Thank you.
Welcome.
This is me now. It is 12:30, almost 12:30 in Dubai. So I'm struggling to keep my eyes open. So I have a suggestion, Dr. Gdih, for the audience. We have actually, just a second to stop sharing. I have on Telegram, Sinjab Academy, on Telegram group, which includes more than 2,400 people, okay, or ophthalmologists. So if you don't mind, I'm going to receive all of these questions, because all of the audience are members in the group. So please ask all of your questions in the group, and I'm going to convey these these questions to Dr. Gdih. And on his pace, he can answer, and then I forward the answers to you. So this is the best way, because I see very important questions. All of them are important. I see plenty, maybe more than 40 questions. If we want to answer all of them, maybe we will need 1 hour more. What do you think, Dr. Gdih?
Yeah, that makes sense.
If you don't mind, huh?
Yeah, of course. Yeah. No, you know, we value your time, and it's beyond now. It's almost the next day at your place, and you have to be ready for your next day. No, I don't mind at all. You know, you can send it to me, and inshallah, I will answer the best I can.
Thank you very much. I really appreciate. Okay, thank you, everybody, and yeah, please ask in the Telegram group, and I'm going to do the idea with Dr. Gdih and Dr. Munir, of course, if Dr. Munir doesn't mind as well, to share us his answers. What do you think, Dr. Munir?
Pleasure.
Thank you very much.
Good idea.
Thank you, everybody. I'd like to thank Dr. Gdih for this wonderful presentation in all measures, really in all measures. يعني, like what we say in Arabic, بتعبي الدماغ. It fills the brain. And it was very clear, very simple, direct to the point, and very systematic. Thank you very much, Dr. Gdih. And I would like to thank Dr. Munir for being with us. Always supportive, mashallah, always. Your presence is very important. And of course, special thanks to Dr. Tariq Sha'rawi, who tried his best to be with us in spite of his injuries, in spite of his surgery, and he is not with us now. So thank you all. Thanks for the audience to be with us. And inshallah, see you in the 4th episode.
Inshallah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Yeah, tell me, Doctor.
Yeah, I just my brothers in Algeria and Morocco. I hope I didn't run it too fast for them. So I would love to hear their feedback in case I need to change the way I spoke.
You can write your feedback.
Yes.
People, please,
Okay.
friends from Morocco, Algeria, Tunisia, please, you can write now in the chat whether it was, yeah, you see, it was excellent from Algeria, you see? I'm sure that our brothers as well from Iraq, perfectly excellent.
Okay, well, thank you, everyone, and we'll look forward to the next one, inshallah.
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 Yalla. Assalamu alaikum wa rahmatullahi.